Good afternoon. My name is Monica Stinson, and I am the Senior Program Manager with the Mississippi Public Health Institute, where I lead the Mississippi Perinatal Quality Collaborative and the Doula Program. Today, you are attending the first session of a four-part webinar series. Each session in this series will address critical topics in understanding and addressing substance use disorders. If you are not registered for the next three webinars and are interested in attending, you are still able to do so via the registration link. Today's course is approved for 1 hour CE for the following disciplines: chess, map, and social work. You must complete the evaluation at the end of the session in order to receive credit. So make sure you complete the evaluation that we put in the chat at the end. Today's topic is the role of the provider in addressing substance use disorders and opioid use. Our speaker today is Dr. April Miller. Dr. Miller is a program manager at the Mississippi Public Health Institute, and her current work is focused on the intersection of substance use disorders and domestic violence. Through this funding, the team is providing substance use and related trainings for domestic violence professionals and staff, as well as implementing telehealth and recovery peer support services to domestic violence survivors with co-occurring substance use disorders. Prior to October 2024, April was the Strategic Prevention Framework for Prescription Drugs, the sport coordinator at the Mississippi Public Health Institute. In this role, she provided education and training on substance use screening, treatment, and prevention to healthcare providers throughout Mississippi. Before joining the Mississippi Public Health Institute, sorry, I lost my screen. Before joining MSPHI, she worked as a pharmacist in a retail and hospital setting. Dr. Miller has 15 years of pharmacy practice experience and an extensive knowledge of pharmacology. In addition to earning a Doctor of Pharmacy degree from the University of Mississippi School of Pharmacy, she also possesses a Bachelor of Science in Pharmaceutical Sciences and a Master of Science in Health Informatics. We will leave a few minutes at the end of her presentation for Q&A. And as always, if you have any questions for our team, please do not hesitate to contact us. Thank you for joining us today, and I will now turn it over to Dr. Miller.
Thank you, Monica, for that introduction. I'm excited to see so many people joined in today on your lunch break for us to talk about. This just serves as the introduction and the overview of, hey, what's happening here in Mississippi and what are the things that we can do to do our part. So we will just jump right in and start. So today our learning objectives is, I hope that you're able to examine the opioid and other illicit substance trends in Mississippi to see what areas have the highest need for opioid and other substance use interventions. Hopefully you will be able to identify patients that are having risky use patterns or a true substance use disorder through a couple screening methods. Thirdly, be able to define stigma and most importantly, understand the effects that stigma has on the identification, treatment of risky substance use and substance use disorder, as well as be able to utilize federal and state resources to help guide appropriate prescribing of opioids, treatment of pain, and adequate patient-provider education to help increase awareness of opioid risk and most importantly, to help prevent overdose and deaths. So I know we all are constantly hear about the opioid epidemic everywhere we turn, and it's always on the news. But today I want to help you get up to date on what's currently happening, where it's happening in our state, and why you should care. All in hopes of encouraging you as a provider to step up and help us in the fight in preventing substance use disorder and decreasing overdose and deaths here in Mississippi. So the opioid epidemic started back in the late 90s, early 2000s with the first wave, which was a rise in prescription opioid prescribing. And then after the prescribing increase, we started to see the rise in opioid deaths from these prescriptions. Then in 2010, as they started to get a handle, there was some awareness of prescription misuse. And we see that some people turned to the streets to heroin. And that was the second wave of the opioid epidemic. And that quickly turned, as you can see in 2013, to the synthetic or the fentanyl wave of our opioid overdose epidemic. And then now we are actually in the fourth wave, which is still fentanyl, but also polysubstance use. We've seen a lot of methamphetamine and prescription stimulants, or two of the biggest things that we see mixed in with these opioid deaths. So looking at our nation overall, overdose deaths from January of 23 to 24, good news is that there was a almost 5% decrease in deaths nationwide. They had predicted 105,000 deaths, but we actually had around 102,000. But still, even though it's great that we had this 5% decrease, but still this translates to 280 deaths per day in our United States. Previously, the year before that, it was at 300. So we're making strides in the right direction, but we still have a way to go. When we focus in on Mississippi, as you can see, we started tracking back in 2015. And so back in 2015, we had about 340 overdose deaths. And these are overdose deaths from any substance, not just opioid specific. And they stayed there in the 300s range. And then you can see that as the pandemic happened in 2020, we had a drastic spike. And we've reached our highest numbers in 21, which was in the peak of the pandemic. And so with the pandemic, we had lots of isolation. People were staying at homes. They were working from home. And we know that addiction and substance use problems often get worse when people are in isolation and aren't connected to friends and loved ones as much as normal. Then we start to see that decrease in 22 and 23. And we do not quite have the 24 final numbers out, but I believe it's on track for it to be down again. I don't know exactly how much, but definitely down a little bit from there. So we can see from 22 to 23, we had 10% decrease where the nation had 5. So this is one of those things that Mississippi is actually doing really well. So many times we're at the end of the pack, but as far as substance use, we are doing really well. But still, this number translates in 2023 to where we had almost 1.7. So somewhere between 1 to 2 people each day died in Mississippi from a substance overdose of some sort. It may not have been only opioids. It could have been something else as well. So when we look at what substances people are abusing and the overdose deaths are related to, over 70% are opioids, followed by amphetamines at 42%. Cocaine would be third, and then heroin is just a tiny sliver there at around 5%. And I would say that it has even decreased more since 2021. And yes, I know it's a pie graph, but it does not add up to 100 because of the polysubstance use that some people have, those multiple substances, alcohol, opioids, amphetamines. They have multiple things in their system at once. But still, I thought that using the pie graph so you could see the breakdown was still the best way to translate that. According to the CDC, in 21, we had 45 people that died from prescription overdoses. And so while everything is fentanyl in the market, we still are having people die from the prescription opioids. So that's why it's still important for us to talk about the prescribing guidelines. And the biggest thing in the community is talking to people, and we'll get into this, about what to do when they have leftover prescriptions, and when they have those prescriptions in their house, where to best store them so that they don't get into the wrong hands of someone. This data comes from the Mississippi Opioid and Heroin Data Collaborative, specifically from our prescription monitoring program. So for those of you that don't know, our Board of Pharmacy in the state has a system where all prescriptions that are filled that are controlled substances, and this includes opioid pain pills, but it also includes stimulants like Adderall and other drugs that have abuse potential. All of those drugs require a person to bring their ID in. And so in the system, they capture all of these controlled substance prescriptions, and they go into a database. So each prescriber is required to check this database, and this has done a tremendous job in decreasing where we had doctor shopping, where people would go to multiple doctors to get a prescription for the same medicine. Sometimes people, if they had a tooth problem, they might go to several dentists within a day or two range just to get more and more pills. And so all pharmacists and all prescribers are required to check that system before they dispense a prescription or write a prescription. But we also keep stats of how many opioids are we having. So there's about 6,000 or so opioid prescriptions per day throughout our whole state. And when we break that down into something that means something, that's enough prescriptions for 77% of all Mississippians, which we have a little over 2 million people as our population, to have received one prescription from a provider. And then when we look on the right-hand side at the number of dosage units, when we divide the number of tablets that were dispensed by the number of population, there were enough opioids prescribed in 23 for every Mississippian from 0 to 100 plus to have received 40 dosage units or 40 tablets. So that's still quite a bit out there, thus the need to continue to talk to people about opioid safety. These two maps really show where are we having our biggest issues. So if you look on the left, this is overdose deaths, and these are actual fatal overdoses divided by the counties. And so the darker the orangey yellow color it is, the more deaths that we had. And where it says 0, that is not necessarily 0, because deaths with a smaller amount, they suppress some of that data to where the MBN has that data, but they don't pass that data on down through the health department and to MSPHI and stuff. But so you can see from this map that out of the 392 total overdose deaths in 23, the coastal area down here, Jackson and Harrison County, is a problematic area. Up in DeSoto County at the top of the state, then our Hines-Rankin area in the center of the state, and then in the north portion of the state, the northeast portion up in Lee County, Tupelo area. Then switching over to the right-hand side, these are naloxone administrations. And so we want these numbers to be high. So the total naloxone administrations that were reported through the system through EMS, so a 911 or an ambulance was called to the scene, was over 3,000. And you can see that the darker the green, the more naloxone overdose situations we had in those counties. And so then once again, down on the coast, Jackson and Harrison County, and even extending into Hancock, Pearl River, and all the way up Lamar, Forest, Jones, all of those. Then once again, our Madison, Rankin, Hines area, then up at the top of the state, in the northwest corner, DeSoto and all those surrounding areas, and then some over in the Delta, Washington and Bolivar counties. And so we want these areas over on the left where we have the overdose deaths. It's good that when it matches up that, okay, so we had a lot of overdose deaths that are happening here in Jackson County. And also, thankfully, we're having a lot of naloxone administrations. Or else those numbers over on the overdose deaths could have been even higher. And so our goal is naloxone saturation, getting naloxone into the hands of as many community organizations, people, as we can, having it in community areas to where if there's someone that has an overdose, that there is naloxone there, because when you're dealing with an opioid overdose, seconds really count. So this is just a little more in depth about our non-fatal overdoses. And like I had pointed out on the last slide, this District 8, which is our coastal counties, is the top area for non-fatal overdoses, followed by our Jackson Metro and surrounding counties, second. And then third would be up in our DeSoto and the counties surrounding the Memphis area. So when you look at the top 5 public safety districts, 75% of all the total non-fatal overdoses come from these 5 districts that are at the top of the list in this table. So District 8, District 1 and 3, and then also District 7, which are those coastal counties that or coastal adjacent counties, and then up in 4 in the northeast portion of the state. So based off of these maps and how they change over time, this is how our Department of Health, the Department of Mental Health, MSPHI, and other community organizations that are helping to get naloxone out there and do awareness and all these things, that's how they know where to concentrate their effort. And so tracking this data is very important, and it is making a true difference. And this is just showing you, this is by rate. So rate is when we adjust for population. So even when we adjust for rates, the coastal counties, District 8 is still the #1 area for non-fatal overdoses. But the thing that changes the most is when we adjust for those population differences, is that we see that District 7 and District 9 are in the second and third place, where they were way down the list when we were just looking at gross numbers instead of rates. So now let's take a few minutes to focus on substance use disorders and how can we best identify patients that are at risk or may already have a substance use disorder that actually needs some treatment. The best way to do that is through screening. And first of all, we will talk about the DSM-5. That is the formal criteria in the psychiatric medical world. But SBIRT is something that a tool and a process that we can use to actually screen and identify these patients to get them whatever level of help they may need. So when we're looking at the official diagnostic criteria, there's 11 criteria, and depending on how many of those criteria you have, they classify it as a mild, moderate, or severe substance use disorder. And so it's things that you think about that pretty much make sense. So taking the substance for longer periods of time or in larger amounts than intended, not being able to cut down on your substance use, spending lots of time obtaining, using, and recovering from the substances, experiencing cravings or intense desires for the substance, failing to fulfill obligations, missing work, missing school, not being there at home to do the things that you need to with your family. The rest of the criteria, continuing substance use despite having interpersonal or social problems. And we see a lot of conflict because as people progress further into their substance use disorder, they do have those interpersonal conflicts because they're having to, a lot of times, lie and they're not following through with the things that they say that they're going to do, because no matter how important their family and their loved ones are to them, that the overwhelming cravings and that need of their brain to get the substance, no matter what the cost, just overwhelms them, and it causes them to have these issues. Giving up your social recreation or occupational activities, getting fired from work is a big red flag that you probably need treatment for a substance use disorder. Using the substances in risky or dangerous situations like driving, continuing to take the substance despite physical or mental problems that are caused by the substance, and then tolerance, where you need to take more and more of the substance to get the same effect, and then withdrawal, meaning that if you do quit taking the substance for a amount of time, that you get very unpleasant withdrawal symptoms, and that usually causes the person to go right back to the substance and start the cycle over again. And so that's a lot of criteria, but this is the takeaway that I would like you to have from that, is if you just think of all the signs of addiction as the 3 C's. So loss of control, whether that's in their family life, their social life, their work life, negative consequences, things like going to jail, getting a divorce, various things like that, and then cravings. And so just think about the 3 C's, and that pretty much sums up all those 11 criteria that we just talked about. So this is the most important part. And as you can see, there's a QR code as well as a website link there. And Monica will be sending out these slides at the end of the presentation. So don't worry about having to write all this down, or all the links will be sent out to you. So SBIRT, it is a process that just stands for, the S is screening, B and letter I stand for brief intervention, and then the R and T is referral to treatment. So screening, we want to do universal screening, to where every patient at every encounter that they have in the healthcare setting, and with counselors, even at other places like domestic violence intakes, you can do these screeners. You don't have to be a licensed healthcare provider to do the initial screening. So these screeners can be anywhere from 1 or 2 questions all the way to 10 or 20 questions. But usually the briefer, the better, to initially get a feel of where the person is. And not to, if you give them a 20 or 30 question screener, sometimes people will just know they might not do it, or they just mark stuff to hurry up and get through. So screening, and then based on the results of the screeners, that's when the provider or the counselor, whoever the person is, can do a brief intervention. And that's basically just a small chat. And so during that, you're going to talk to them and say, hey, based off of the results of your screener that we just took, it looks like, or tell me about your drinking, or tell me about your substance use. And it's always best to ask them to tell you, versus if you tell them it looks like you were drinking way too much, they may just shut down and feel judged and things like that. And then the final step, based off of once you do that screener, and if there's a need for a brief intervention, sometimes you'll give them a more in-depth screening exam at that point, or refer them to a provider that can do that. And then based on those results and that conversation, they may need some outpatient treatment. They may just need to be referred to AA, or to be, if they're early on and it's just risky drinking, just educating them about how many drinks is a healthy amount, and encourage them to cut back, and coming up with a solid plan on how to do that. Sometimes that's all they need to prevent this risky event from turning into severe substance use disorder that can, be life altering for that patient. So that's why screening often, and at every encounter that a patient has in the healthcare settings, emergency rooms, your primary care doctor, your specialist. That's the ideal goal, is to have screening for substance use everywhere. So why do we want to do this? Using the screener, it normalizes screening for individuals. We all are used to having a yearly physical where we get our cholesterol and things. Women have their mammograms. When you get a certain age, we do colonoscopies. And so we want our substance use screening to be just as routine and normal for people as any of the other health screenings that we do. Then it is a good way to start that conversation and to find out more and identify risky behaviors in patients. Because the sooner we can intervene in the substance use cascade, the better the outcomes for long-term are. It can help the patient with self-awareness. They may have not realized that the amount that they were drinking was a problem, and it may have snuck up on them since the last appointment they had. They come back to you the next year, and oh wow, when they fill that form out, they realize that, ooh, I have been drinking way more than I should. And then, of course, this all helps to prevent substance use related diseases, accidents, injuries, deaths, reducing healthcare costs. And for those of you that are actual healthcare providers, expert for people that you have a brief intervention and refer them to treatment, you can bill Medicare, Medicaid, and some of our commercial insurance. They actually have billing codes, and the billing codes are there on that SBIRT MS website. Or if you have any more questions about that, you can reach out to me and we can get that list for you as well. So stigma. Stigma is a huge issue with when we look at substance use. So stigma is basically a negative set of beliefs that society or a group of people have about some sort of identifying issue that someone has, whether it be addiction, obesity, mental health, HIV status. All of these are highly stigmatized conditions. And a lot of times people that are stigmatizing people, they view it as an issue with the person's character or their choices instead of as a true disease that the person can get help for. And stigma is probably the number one barrier to identifying and people asking for help. It's very, very hard for someone to, go in and admit that, they're struggling and can't stop drinking, or that they have gotten addicted to a substance. It's very scary just because of all the stigma for so many years. And so that's why, again, that our screening process of SBIRT helps to be a bridge to decrease that stigma and get the conversation started. So stigma can have lots of effects on people. We see that when people are stigmatized for their substance use or alcohol use, we see that they have lots of shame and hopelessness. They can isolate and avoid people. They're hesitant to seek care or to be honest with their providers about their use. And why? Because of that fear of judgment. Stigma can cause unemployment issues or people not being able to find a job. If someone knows that they have a substance use issue or knows that they just got out of rehab, we have issues in that realm. And also lack of healthcare resources. So stigma affects everything. So I like to think about everybody that is here that's a healthcare provider or works in related fields. All of y'all went into these fields because you care about your patients. So the easiest way to combat stigma is to remember the acronym CARE. So what does that stand for? The C is cultural awareness. So cultural awareness can play a big role in your attitudes and beliefs that can positively influence the way someone thinks about a group of people or society as a whole. And so if you have patients from different cultures, understanding what the norms are and educating yourself so that the way that you interact with that person makes them feel more comfortable, that is a great way to bridge the stigma and help them to open up and trust you. The A is avoid stigmatizing language, and we'll talk about what that looks like in just a minute. The R is for rapport and relationship building, because if the person doesn't feel that you care about them as a person, they're not going to open up and talk to you and trust you with something that is so scary to talk about. And then E is for empathy, or empathizing with the patient. Being able to understand what that person is going through and relate to their situation as if you were in that situation yourself is ideal. So person first language helps to avoid stigmatizing language. So instead of calling someone an addict or a junkie or a drug abuser, we want to avoid those terms and instead talk about it more scientifically in medical terms, that a person with a substance use disorder, or a person with opioid use disorder, a person with alcohol use disorder, or a person that misuses alcohol. Instead of calling someone a former addict, we can call that a person in recovery or long-term recovery, or a person who previously used substances. Instead of a habit, we want to call it what it is, a substance use disorder or a drug addiction. Although in drug addiction in some terms is fine to still use that word, but overall we kind of want to avoid the word addiction or addict as much as we can. Abuse, instead of using the word abuse, use or misuse. And then instead of relapse, just calling it return to use. Relapse has a connotation of failure, and that you're just doing it again, and has less hope. So the new preferred favorable term instead of relapse is return to use. And so building that rapport and that relationship with the patient. These are just a few of the things that you can do. Be genuine, follow their lead, use their name, ask questions, actively listen to them instead of typing on your screen and not looking at them. I understand you have things that you've got to get done and charted or written down, but there's nothing to replace that eye to eye, listening to them, asking questions. That's how they know that you do care and that you can show empathy. You can't show empathy very well if you're not actively listening. And so these are things that we all know about, but just a reminder to put them into play when we're dealing with our patients or with clients. And then just a few tips about how to best practice empathy, perspective taking, or putting yourself in someone else's shoes, listening instead of judging, listening to understand, and then recognizing emotions in another person that you have felt before. Even if you haven't had that same exact situation, you can think of a similar situation where you had that same sort of emotion and relate and connect with the person in that way. And then communicating that you actually recognize that emotion to them are some tips for empathy. And so now we're getting into the more clinical part of it. So what can we do to avoid opioids when we want to treat someone's pain? If you're a prescriber or a nurse or a pharmacist, what are the regulations around prescribing an opioid? And then most importantly, and the part I want to spend the most time on, is talking about the risk and the things that the patient education piece of what we need to be telling these patients that are on opioids. So the CDC, our Centers for Disease Control, they came out with pain guidelines in 2016, and then they updated those guidelines again in 2022. The guidelines pretty much stayed the same, except for the biggest change was an emphasis on treating the individual person and not using these guidelines as ultra rigid rules that apply to everyone, but to realize that clinical judgment and flexibility is the key to best using the guidelines. So I'm going to run through all the guidelines with you real quick. And so the guidelines include, number one, non-opioid therapy is preferred for all types of pain. And we'll talk about what that is, but think Tylenol, ibuprofen are your basics. Number two, if you do use an opioid, we want to avoid extended release and use an immediate release at the lowest possible effective dose. And typically that's starting out at around 2.5 to 5 milligrams of hydrocodone or oxycodone every 6 hours or so. Number three, do not abruptly stop an opioid without tapering and further follow-up and evaluation. The reason that this is such a big emphasis in the guidelines is that early on, when the 2016 guidelines came out, doctors and other providers, due to fear of getting in trouble with their medical boards and other things like that, they went and just, the pendulum swung way too far in the other direction too quick. We had been putting anybody and everyone on opioids and telling them they're not that addictive, don't worry about it, we need to treat pain. And then the guidelines came out and everybody came over here, and there were a lot of people that were abruptly stopped. And that's when a lot of people went out and heroin, we saw that because these people, they were cut off immediately and they start getting these horrible withdrawal symptoms, and they don't have anything else to do. So they went and did the thing that made the most sense to get them that immediate relief. And so we're doing pretty good on that, but that's why they made a big emphasis in the updated guidelines about, not to abruptly stop someone. Other guidelines, prescribing opioids for the shortest duration possible. Usually if someone has some acute pain, dental pain, or if they break a bone or some other sort of acute injury, 3 to 5, maybe 7 days is all that they really need. And then they can transition to another type of pain relief medication that doesn't have all the risk of opioids. Moving on down the list of CDC recommendations, evaluating the risk and benefits, especially for people that are going to be on long-term opioids. You want to, if someone's having a condition that is going to be, that they're going to be on opioids for a month or 2 or 3 or longer, we want to make sure that we bring them in the first week or 2, and then at least every 4 weeks thereafter, to monitor their effectiveness and make sure that see what's going on. And if it's not working anymore, because opioids, they do work very well early on, but the longer you take them, just naturally the way that they work in your body, you don't get as much of pain relief from them the longer you take them. So you want to bring these people in often, so that when they get to that point where they're not getting pain relief from the opioid, that we're not just having them on it, because at that point they're just going to be exposed to all the risk of potentially becoming addicted and overdose and potential death. Moving on down the list of recommendations, chronic opioid therapy should be an intentional decision. And so that goes right hand in hand with evaluating the risk and benefits. For those people that have pain issues that linger for several months or even longer, we want to make sure that we're not just renewing that prescription just like each 6 months or a year you go in and get your blood pressure medicine and they just keep writing that same prescription over and over, that someone is actively monitoring that pain condition and not just keeping a person on an opioid when it's not working or is causing the person adverse effects. The CDC recommends co-prescribing naloxone, and now naloxone is available over the counter, so it doesn't really require a prescription. And the great thing is in Mississippi, you can go to odfree.org and anyone can request naloxone and be sent to their house at no charge. And it comes within a few days. So making sure that if you have an opioid prescription, that you also have some naloxone on hand just in case. Other recommendations from the CDC include checking the prescription monitoring programs in your state, and using toxicology, urine drug testing, and things like that for people that are on long-term opioids. So with the urine drug testing, there's two things. We want to, number one, make sure that the medication we're being prescribed is actually in their system if they're on chronic opioid therapy, because unfortunately, there are some people that sell their pills and divert them out there. And so you want to make sure that the patient's actually using it, because if they come in and there's no opioid in their system, then you've got some questions, and it brings up whether or not, they're doing something to divert that medication instead of using it themselves. And then also to monitor for other substances that maybe they didn't disclose. Perhaps they're also on marijuana or meth or various things. And if you see some other illicit substance come up, then the chances of them having a substance use disorder is higher. And then you would want to address that issue, and the fact that they're on an opioid is in that danger zone anyway. And so that's kind of the rationale behind the toxicology testing. And then the final recommendations include avoiding the combination of an opioid and a benzo. And so benzos are things like Xanax, Klonopin are two of the main ones we see out in the community. And so when you use these two drugs in combination, the chances of an overdose, because they're both depressing your central nervous system, drastically increases. And then this is a new recommendation for the updated 2022 guidelines, is that to offer treatment with evidence-based medications for opioid use disorder for those people that are identified of having a problem with opioids. And so what does that look like? That would be methadone, but more commonly that would be buprenorphine, that most people are familiar with it by the name brand Suboxone treatment. And what that does is that replaces the patient's opioid that they were taking, but in a lower dose that they don't get the euphoric highs, but it keeps them from getting the cravings that cause people to relapse. And so the CDC upped the strength of that recommendation to actually offer treatment with medicine. Before, it used to just be offer a referral to treatment, and not necessarily medication-based treatment, just counseling and or inpatient or outpatient substance use treatment programs. So in Mississippi, there are some particular rules that the Board of Medical Licensure has, and they do align well with the CDC guidelines. So you do have to access the prescription monitoring program anytime you prescribe an opioid. They have some duration and quantity limit suggestions. The Mississippi regulations also encourage avoiding prescribing opioids and benzos together. And then Mississippi actually implements those drug screening requirements. So the prescription monitoring program, all pharmacists and all prescribers, nurse practitioners, physician assistants, advanced nurse practitioners, all of those people that have any kind of prescribing, dentists, prescribing rights, they all are required to register, and you have to check every time you write a prescription. And then if the person's going to be on it long term, you got to check it at least every 3 months. And you need to, the biggest thing is that it has to be documented in the chart that you reviewed it. But it's not required if the patient's in the hospital and taking opioids just in that hospital setting. But if they're going to go home on an opioid, that prescriber does have to check. So the Mississippi actually has some numbers. And so for acute pain in Mississippi, the medical board recommends less than a 3-day supply of pain medications is ideal, with a max of a 10-day supply can be dispensed at one time, and they can be given one additional 10-day supply before they have to go back in for a face-to-face visit with that prescriber. And then with chronic pain, the how strong your dose of opioids are is referred to in MMEs, or morphine milligram equivalents. And so the guidelines and the Board of Licensure recommend to stay under 50 MMEs and to try to avoid going over 90. But then we also have a regulation in our state that if you're over at 100 or over, that you have to get a pain consult with a pain management prescriber that is certified in pain management. And so Mississippi aligns on the co-prescribing of opioids to avoid that. All benzodiazepines, that's Klonopin, Xanax, and as well as pain medications, have to be drug tested if you're going to be on them long term, at least 3 times a year. There are exceptions for patients you see listed here. If you're in hospital, if you're a hospice patient, end of life care, or if you're a active cancer or terminal cancer treatments, you don't have to do the drug screens. And then certain medications that you see listed in the far right-hand column, amphetamines for our children and teen population that are diagnosed with ADHD, and Sudafed, and some other drugs. These drugs have significantly less addiction potential, and so that's why they're exempt from the urine drug screening. And so ideally treating pain, we want to use non-medication options if we can, then non-opioids, and then opioids as a last resort. And so non-pharmacological treatments, that can be anything from self-care, simple things that we learned a long time ago in first aid: ice, heat, rest, elevation, chiropractic care, massage, physical therapy, occupational therapy. These things can do wonders to help chronic pain. Unfortunately, a lot of times insurance doesn't reimburse for them, or they have limited reimbursement. And so that's why we don't see them used as widespread as other things. And then lifestyle changes like exercise and weight loss. People in our society, we want a quick fix. And so if you take a pill, you get that instant relief. But sometimes things that are lasting changes that really make a difference, they're slower, like weight loss and things like that. And actually CBT and mindfulness, there's a lot of information out there that mindfulness can help with chronic pain. And I'm going to just skip over these real quick so that we can get to the other thing. But topical a topical example of a medication to treat pain would be icy hot. And also there's a diclofenac gel that's very good. It is a NSAID, which is like ibuprofen. And so it works very good on knee, ankle, shoulder, wrist type pain. And the great thing about using a topical is that you're going to get little to no systemic side effects. But often if you have widespread pain, you're going to need some sort of an oral. That's where our mainstays are Tylenol and NSAIDs. The big thing about NSAIDs are our ibuprofen, naproxen, Celebrex is a prescription NSAID that you can get. With those drugs, the wonderful thing about that is that if you do need to use an opioid, if you mix an opioid with an NSAID, you don't have to take as high a dose of the opioid. The two work together. And instead of it being a 1+1 effect, they're boosting to where If you said that an NSAID gave you 1 as a quantity of pain relief and the opioid gave you 1, when you add them together, you would be getting more than 2. And then there's some other alternative medications that are particularly useful in long-term chronic pain. Opioids, there's in that 3-day range, and trying to stay with less than a week supply. These are some sites that you can go to that have some great things. They have podcasts, they have lots and lots of good continuing education and case-based things to learn more about, because there's so much about treatment of pain and opioids that we can't possibly cover in 1 hour. And so those are 2 things that are great to go to. So opioid risk, anytime a person's going to be on an opioid, we need to make sure that they understand that there's a risk of dependence, and that dependence can turn into a substance use disorder, and that they're at the risk of an unintentional overdose, and that overdose can result in a fatal overdose. We want to screen to see if they have a family history of substance use, or a prior history of substance use themselves, and then anyone with mental health disorders of any type. Anxiety, people with depression, all of those things put someone at a higher risk of developing addiction if they're exposed to an opioid. And so asking those questions before you prescribe an opioid. Some factors that increase the risk of overdose death, if you use an opioid with alcohol or other drugs, taking high doses, taking more or more often than prescribed, obtaining additional pills online or from an illicit source, and certain medication conditions. If you have sleep apnea, or if you have reduced kidney or liver function, these things can cause you to be more prone to overdose because your body's not processing that drug as quickly. And then as we age, our metabolism of medications slow down. And so what might be a therapeutic dose for someone when they're in their 50s, if they're 85, that dose might be a dose that could cause them to have a fatal overdose. So what does overdose look like? If the person is seems to be passed out, you try to wake them up and they're not easily aroused, pinpoint pupils, slow or shallow breathing, pale, clammy, cold skin, and just lack of response. So if you see someone if you encounter someone with these any of these symptoms, first of all, we want to call 911, administer a dose of naloxone if we have one, and then the big part is for someone to stay there with that person until EMS arrives, and encourage that person to go with EMS, because a lot of people, once they get the naloxone and it revives them, they'll want to get up and just run away. And knowing that the naloxone, even though it got them out of the overdose, depending on how much and how strong the opioid was that they used, they could easily go back into an overdose situation without taking any more. And so that's why the stressing that they need to go see a healthcare professional if they do have an overdose is huge. Locking up our medications in a box, if possible, if you're on long-term, or at least keeping it in areas that, in your bedroom, not in the guest bathroom where anybody that walks into your house could find it. Disposal of unused medications. Most of our sheriff's offices have boxes where you can drop it off. A lot of local pharmacies do as well. And then the DEA has take back events every April and October, where they'll set up at a community event or at a local pharmacy, and you can bring all your medicines. And you can bring any medicine. It's not just a controlled substance. You can bring any kind of prescription medicines that are left over, or if someone in your family had passed away, you can bring their medicines and dispose of them. So this is a great resource, odfree.org. If you don't remember anything else today, remember odfree.org. Number one, you can go there to order naloxone. And number two, you can also go on there to where it says get help, and you can type by zip code and it will tell you your treatment options. That's what the naloxone kit looks like that would come to your house. And this program is great if you know anyone that does have an opioid use disorder and they're interested in trying medications. Our health department has this great MSOD program where they can do a telehealth visit at a local health department. And then the medications are also provided and shipped overnight to the patient. And you can go to that link to find out more about that, or reach out to me and I can put you in contact with the right person for that. So that's all I have today. Does anybody have any questions? I know we're about to be out of time, but if you have any questions and you don't want to ask them now, or you don't have a chance to ask them now, please email me at amiller@msphi.org, or you can call me. My phone number is listed there. And I would be glad to talk to you and answer your questions individually.
All right, great. Do we have any questions for Dr. Miller at this time? If you do, you are more than welcome to come off mute. Also, just two quick housekeeping things before you jump off. The evaluation is dropped in the chat. So if you are seeking CEs, or if you need a um, certificate of attendance, please make sure to fill out the evaluation. But also, everyone, please fill out the evaluation. And then I'm also going to drop the presentation into the chat. Um, April has some very good information in there, and you will be able to go back and reference. So I'll be quiet. You see the evaluation link, and I'm dropping the presentation in there as well. No questions? No questions. All right, well, we will hang out here for just a minute. So if you need to have a few minutes to download the presentation and complete the evaluation, it would be good to go ahead and complete it now so that you won't forget. The evaluation will be closed by the end of business day tomorrow. So make sure to go ahead and complete it right now while you remember, because I know I'll forget.